Hello, it's Adam again, and today we're going to be covering the second part of our neurology section for class. Again, I apologize for having the video up late, but today is the first day I've been able to have any sort of voice. The days previous, I was sounding somewhere between Smeagol from Lord of the Rings and like I was hitting puberty. So I figured recording a video for all of you to see would not have been super appropriate. So again, I apologize for being late, but here is the lecture. The first thing we'll be talking about after covering all of our antiepileptics is going to be Parkinson's disease. So a few things that we know about Parkinson's disease. The definition, and this will be really important for the rationale for the drugs that we select, is this going to be a slowly progressive neurodegenerative disorder. That the main issue here is the loss of these dopaminergic neurons in the substantia nigra. And we know that these neurons are very, very important for movement. And so when you have this progressive loss of the neurons, you end up having these kind of four cardinal features of Parkinson's. You have tremor, you have this rigidity that can occur, this hypokinesia, so kind of slowed, lack of movement, and also this postural instability. It's believed to be affecting around 1% of people over the age of 60, but that population may double, in the next 20 years or so, just due to the fact that we're living longer. As life expectancy increases, you're going to see that these more chronic conditions are more prevalent in the older population. We end up seeing is that the incidence begins to increase after the age of 40, and those that are more likely to be affected by this. They have certain genetic changes, but certainly 95% of those cases are mainly going to occur after the age of 60. So this is typically more seen in your more elderly population. The incidence that we see here is that it's going to be higher among men, and also possibly people who have European or African descent in America. It seems to have a little bit higher incidence for whatever reason. Interestingly enough, some of the things that look like it may prevent or lead to a lower incidence, and again, it may not be causation, it may just be a correlation. They actually see lower incidence in patients who smoke, consume caffeine, and even take NSAIDs. Either regularly or chronically. So again, probably not a good idea to start taking up smoking if you don't already, but just an interesting thing that they noted in some of these population studies. So the etiology, there's lots of different things, lots of different reasons why a person may develop Parkinson's. There's thought to be some genetic links to this. So if you have certain polymorphisms in some of the following proteins and genes, they end up seeing an earlier loss of these dopaminergic neurons that could lead to Parkinson's. Some people believe that there's kind of idiopathic kind of process going along as well, where it's just as the person's brain ages, you're going to have some degeneration over time. So it's not necessarily related to any necessarily genetic predilections for Parkinson's. And then interestingly enough, we also have some drug-induced Parkinson's type conditions, as we've already talked about with our antipsychotics. When we were talking about the behavioral medicine section, we see that anything that is blocking the effects of dopamine, either pure dopamine antagonist, or if you have atypical antipsychotics, you end up seeing this blockade of the dopamine receptors, which can lead to, even though the dopamine neurons are still firing like they normally would, you're still blocking those receptors. That could lead to almost like a drug-induced Parkinson's. Some other medications that work to deplete endogenous catecholamines, including norepinephrine, including dopamine, would include methyl-dopa, which we see used for hypertension in pregnant women for preeclampsia. And then also a very old school drug called reserpine, which we talked a little bit about briefly during the depression section. It's one of those drugs that basically just wipes out all of your endogenous catecholamines, leading, could cause depression, can cause Parkinsonism or Parkinson-like effects. So again, not a drug we see very often, but one that definitely has some historical significance. It's seen that trauma can lead to Parkinson-like symptoms, especially if there's some degree of brain damage, and then also certain chemicals can do this as well. So it's kind of an interesting story. Back when people were trying to make designer opioids. Someone was trying to make kind of like designer Demerol or meperidine, and actually what ended up happening was they formed this compound that produced a byproduct called MPTP. And when this person was injecting this drug that they had produced, and again, most of these street chemists don't necessarily have their world-class laboratories they're working in, or necessarily uh, the science degrees and whatnot to kind of back them up. So when they started randomly injecting things that they've produced into their bodies, they found that this MPTP actually wiped out all of this person's dopaminergic neurons. So they found them in a catatonic state, as you would see with the very severe kind of end-stage Parkinson's patient. And so they actually realized what had gone on, what the chemical was. They were actually able to use that in order to kind of induce have a kind of a model in animals for inducing Parkinsonism they could use for studies. So actually this person kind of had a happy accident in the way that we were able to now research Parkinson's, because we can now do these studies a little bit better, especially in animals and things like that, by inducing a Parkinson's-like syndrome. There's other chemicals that can do this as well, things like methanol or hydrogen sulfide, carbon monoxide, potentially anything that can cause kind of this significant brain damage can lead to some Parkinson-like effects as well. So looking at the pathophysiology here, we know that the substantia nigra is going to be containing these dopaminergic projections that are going to be ultimately synapsing over into the striatum. So I'm going to pull my laser pointer up here. See here, sorry, I'm going a little crazy here, but the substantia nigra here is ultimately going to be synapsing up here in the striatum. You'll see that there's going to be basically two different types of efferent neuron types here. So it's going to be the stimulatory D1 type, and then also the inhibitory dopamine 2 type receptors. Okay, so to get a little deeper into the pathophysiology, again, this is a complicated slide, but the main point is not necessarily to get mired down into all the intricacies of some of these kind of circuitous pathways, but more to just be aware of kind of the complex nature of the disease state, and to realize kind of what the changes, when the changes happen to the dopamine neurons, how this is going to kind of affect this interplay on motor output. So essentially this would be kind of the normal functioning system here, where your frontal cortex is going to be initiating the stimulus for motor output. And normally here, the important thing to remember is that your get my laser pointer out here. The thalamus is normally in an inhibitory state. So normally the thalamus is trying to inhibit motor output in general. And this is being accomplished as well by the globus pallidus interna. Normally this is going to be more of an inhibitory pathway here to the thalamus. So the globus pallidus interna is kind of making, stimulating the thalamus to be more inhibitory, right? So what's happening here when we want to initiate movement or some sort of motor output, there's kind of two pathways we're going to be seeing here. So the first one's going to be with the frontal cortex. You're going to see it's going to be initiating this motor output. In the substantia nigra, you're going to see that the D1 neurons are going to be a positive effect. So it's going to be stimulatory onto the striatum here on these GABAergic neurons. So this is going to be causing more GABA to be released from the striatum through these particular neurons. When that happens, you get more GABA here flowing onto the globus pallidus interna. So this is going to kind of turn this one down and make it less likely to fire. And so by doing that, you're going to end up seeing a more negative effect here. You're going to see less activity here on the thalamus, and so it's going to kind of take off the brakes of it, and so it's going to lead to a net positive effect on these circuits that flow back into the frontal cortex, leading to positive effects on motor output. This is the direct pathway to leading to motor outputs here. There's also an indirect pathway which occurs as well, where you have these D2 neurons that are going to be more inhibitory. So you see with the D1 here, you have more positive effects, more stimulatory effects on the striatum. Here we have this indirect pathway where you have D2 being more inhibitory on these GABAergic neurons. So by D2 acting on these GABAergic neurons, you're going to see less firing here, which means you're going to have less GABA flowing onto this globus pallidus externa, So less GABA here is going to be stimulatory. So it's meaning there's going to be more GABA flowing onto this subthalamic nucleus, which is normally normally releases glutamate onto the globus pallidus interna, which glutamate is the main stimulatory neurotransmitter. So here what we're seeing here is that by having more GABA flowing out here from the globus pallidus externa, you're going to be causing a net negative effect on the glutamate being released from here, meaning that you're going to have less excitatory actions of the globus pallidus interna, which means you're going to have less output here to the thalamus, which means you're going to have a net effect of more positive output onto the frontal cortex, leading to that motor output. So kind of two pathways that lead to increased motor output, with, again, the D1 pathway being positive, being stimulatory, whereas the D2 being more inhibitory. So let's see what happens when you switch over to a Parkinson's patient who has a significant decrease in the amount of dopamine that's going to be firing. So switching over here, you can see here the dopamine neurons are pretty well depleted, and typically once we get up to around 70 to 80% is where you really start to see some of the symptoms start to come about from Parkinson's. So you have a pretty good reserve, but once those get majorly depleted, that's when we're going to start to see the effects come about. So what happens here is when your body is trying to initiate movement, you're going to be seeing the frontal cortex will be trying to stimulate these dopamine 1 receptors, and since that's not happening, there's no positive effect here, right? You're going to be seeing less GABA flowing out from the striatum from these neurons. So because we have less GABA flowing out here, this means that the globus pallidus interna is going to be more active. It's going to be sending out more activity to the thalamus in order to help shut this down, to be more inhibitory. On the indirect pathway, what we end up seeing is that because we don't have this inhibitory D2 receptors or D2 neurons anymore, we are going to be seeing more GABA flowing out from here, which is in turn going to end up kind of shutting down this pathway. So we're going to have less GABA flowing out from here. So this means this glutamate neuron is going to be much more active. So it's going to be firing off more glutamate, being more excitatory, which basically means it's going to be turning this on even more. So now the globus pallidus interna is actually going to be inhibiting the thalamus even more, leading to just basically way less movement happening. So by this pathway, by depleting those neurons, you end up having this just kind of overwhelming inhibitory effect on the thalamus, and that's where we see the hypokinesia and the muscle rigidity and things like that that are very typical with Parkinson's patients. So another big component to this pathophysiology is also the interplay between dopamine and acetylcholine. As you guys remember in our talks about the antipsychotics, what ended up happening when you have blockade of those dopamine neurons is that we end up seeing too much acetylcholine being firing. And we know that acetylcholine is going to have, positive effects on those, nicotinic skeletal muscle receptors and cause tremors and things like that. So kind of the same thing happens here with Parkinson's, where by having a depletion of these dopamine releasing neurons, normally dopamine is going to have kind of an inhibitory effect on acetylcholine being released in the striatum. When you have depletion of these dopamine neurons, which end up leading to that rigidity and hypokinesia, a lot of that's due to the inability to kind of initiate movement. You also end up seeing kind of these motor effects from too much acetylcholine. So this is really where the big place that the tremor comes from, is due to the decreased amount of the increased amount of acetylcholine is being released within the striatum. So looking at dopamine metabolism and production is going to be really important for some of the medications that we're going to use to treat the symptoms of Parkinsonism. So the initial step here is starting with L-tyrosine. We can acquire this from things like phenylalanine within the diet. But basically L-tyrosine ends up getting converted over by this tyrosine hydroxylase. That gets converted over to levodopa. And levodopa is going to be really important for one of the medications that we're going to be talking about. Now, part of it can be metabolized by catecholamine O-methyltransferase, or COMT, which will be is an important metabolism enzyme as well. But essentially, the dopamine that we use to release into the synapse is going to be from this converted L-dopa. So essentially, this L-amino acid decarboxylase, or this LAD, will end up converting L-dopa over into dopamine. Now, dopamine can be metabolized as well. It can be metabolized by monoamine oxidase B, which is going to be really important for some medications we'll see used that will actually work to inhibit that. Also, it can be metabolized by aldehyde dehydrogenase, but we won't see that really come up too much. But once that pathway happens, you end up having dopamine being able to be released into the synapse here. So the other big thing to look at here is also going to be these D3 receptors. Normally D3 receptors are these kind of these autoreceptors that are going to, when they're stimulated by too much dopamine being within the synapse, they're going to have an inhibitory effect. So they're actually going to be preventing less dopamine from being fired. That's kind of just your body's own body regulatory pathway to prevent too much dopamine from being released. So looking at the presentation of Parkinson's, what we're going to see here, the cardinal features are going to be kind of these 4 cardinal signs. So the hypo or bradykinesia, the resting tremor, rigidity, and then also the postural instability. We know there's a lot of motor symptoms, and this kind of runs quite the spectrum from kind of minor to much more severe as the degree of dopamine neuron depletion increases. So certainly you're going to see a lot of motor symptoms where you have this kind of decreased dexterity or clumsiness. You have issues with dysphagia. They're not able to really speak very well. You have all these other issues, hypophonia, micrographia, all these different things where basically, movements are going to be decreased. They're going to be smaller movements. It's going to be difficult for them to actually initiate a lot of actual actions to occur due to this dopamine depletion here. So again, motor symptoms are really going to be the biggest thing you're going to be seeing here, especially from the dopamine specifically. We can also see a number of autonomic symptoms as well that can occur. Again, this is going to be more with more advanced disease. So you can start to see issues either incontinence or constipation. Keep in mind they're going to have a hard time actually taking care of themselves, especially when some of these motor movements are going to be very difficult. And then we can also see things like mental status changes. So certainly confusion, dementia can all be a part of this. And then some miscellaneous effects, so issues with like fatigue, weight loss, especially if they're not able to really feed themselves that well. So lots of different things can be occurring due to this Parkinson's process. Typically, you're going to be, basing the diagnosis on looking for those kind of cardinal signs, and it can be misdiagnosed in a number of patients just due to the fact that sometimes, especially when you're kind of early on, it can be easy to misidentify it as something else. So again, there's no good lab tests or imaging studies that are really useful for confirming the diagnosis. You basically just need to have the ability to base it off of symptomatology. One of the things you can potentially do, though, is that if you're thinking Parkinson's and you're thinking, okay, there's a depletion of dopamine here, well, let's replace that. Let's give them something that will actually end up stimulating or either take the place of dopamine in order to help replace it. So this is where you can give something like levodopa, which again, as we saw before, gets converted over to dopamine, or apomorphine, which is a drug that actually will stimulate directly dopamine receptors. So by giving something that will either take the place of dopamine or get converted to dopamine, if you see that the symptoms improve, well, that kind of gives you a pretty good sign that there's an issue of a dopamine depletion that's happening in that patient. So that may lead to be kind of a positive for your diagnosis of Parkinson's. And again, just remember it's a progressive disorder that eventually is going to result in some pretty significant morbidity. So while it may be kind of missed early on, the goal is to kind of catch it as early as you can to kind of help decrease some of this progression of disease as you move forward. So our therapeutic goals are going to be to try to minimize or reverse the functional disability that's happening here. And if we can, try to prevent or minimize a lot of the long-term complications of both the disease and then also some of the medications we're going to use. So again, these are not going to be completely benign medications. So if we can prevent some of the adverse effects here by looking at either the combination of drugs that we're giving or the doses that we're giving, it's going to be a net positive for our patient. So there's a number of therapeutic options that will be available for our Parkinson's patients, both non-pharmacologic and pharmacologic. Obviously, education and support can be really helpful, along with physical therapy, exercise, and speech therapy for your patients. There's even some surgical options that are out there, they include things like deep brain stimulation. But the thing we'll focus on, and is probably definitely one of the hallmarks of therapy, is going to be our pharmacologic therapy. So we'll see that we're going to have the treatments for both early, kind of uncomplicated Parkinson's, and then more late stage, complicated Parkinson's disease. So looking at our drug therapy options for the early uncomplicated Parkinson's disease, you'll kind of see that we're focusing on kind of two different modalities of therapy. So one, we'd like to look at neuroprotection to try to make sure we're limiting the progression of disease as much as possible. So this is where our monoamine B inhibitors are going to be coming into play, and then also some of our dopamine agonists. And then we'll also see for symptomatic management, you'll see the dopamine agonists and also monoamine B inhibitors will be involved in this pathway as well. But we'll also do some things like anticholinergics and COMT inhibitors, which we'll get more into detail about what all these are in a minute, and then also potentially even some dopamine precursors. And that's actually going to be probably one of the more cornerstone pieces of therapy as we move forward. So looking at early uncomplicated Parkinson's disease and the neuroprotection pathway here, what we want to see is that with dopamine agonists, dyskinesias end up emerging even after we're giving therapy with levodopa. And as you remember, dopamine is produced from levodopa. So levodopa is one of those precursor molecules that we have. And so even patients who are on levodopa therapy, we still end up seeing that these dyskinesias can emerge after several years. Then along with that, after even 5 years of therapy, approximately about 50% of those patients are going to develop some dyskinesias. So the idea is that by initiating dopamine agonists early, the thought is you may actually help delay some of these levodopa-induced dyskinesias. Again, by giving the dopamine agonists, they're going to be acting directly on those receptors as opposed to relying on the brain's own supply of dopamine. Again, this pathway is not fully understood, but it is something that is thought to be helping to prevent some of the progression of disease. On the flip side of that, you have the monoamine B inhibitors, and again, we know monoamine B is going to be an important enzyme for metabolizing dopamine. And so essentially what we see here is that some of the drugs we have will irreversibly inhibit monoamine oxidase B to help reduce that metabolism of dopamine. And so by doing that, by inhibiting that metabolism, it's thought they may actually decrease some of the free radical formation that happens with the substantia nigra. So looking at this here, dopamine will end up getting converted over by monoamine oxidase B. So you end up having this DOPAC being formed plus hydrogen peroxide. We know hydrogen peroxide ends up getting broken down into these free radicals, which can help to do things like damage cells and damage proteins. It can trigger apoptosis to occur. So really, this is going to be kind of harmful to the CNS in general. So by giving these inhibitors here, by preventing that the metabolism of dopamine, it's thought you have less production of these free radicals and thus less damage to the neurons as time goes on. So this is thought to be neuroprotective to help prevent the progression of disease as we go forward. So just as an example of showing the neuroprotective effects of a couple of dopamine agonists. Looking here, we see pramipexole and also ropinirole, which are direct dopamine agonists. And some of the studies they had with it actually showed some interesting results where they actually showed smaller reductions in the number of dopaminergic neurons or dopaminergic function as compared to patients who were taking levodopa by itself. And so, again, don't get caught up in the tests that are done here, but just realize that the dopamine agonist led to a smaller reduction or presumably less progression of disease over time as compared to levodopa. And again, we're not really sure if the dopamine agonists themselves are neuroprotective, or is it just that by keeping them off of levodopa for longer, we're preventing them from being exposed to a neurotoxic effect. It's hard to say, but is an interesting thought that may be beneficial to our patients. Also looking at the neuroprotective effects, we have a couple of drugs here that are going to be our monoamine B, our monoamine oxidase inhibitor, to work on the B subtype of that specifically. So we have Selegiline. So they have done studies to show that this has been found to delay the need for levodopa. But unfortunately, the advantage wasn't sustained over time. Um, and so, interestingly enough, Selegiline will actually test positive on urine drug screens as amphetamines because of some of the metabolites that it has here. Notice it doesn't have any stimulant effects itself necessarily, but it does will certainly show positive for amphetamines on a urine test. A couple of different products we have here. We end up having Elderpril or Zelapar. We can be utilized for this. And then we have Rasagiline or Zelect. Again, this is also shown to help kind of have a reduced functional decline. This one not metabolized over to amphetamine derivatives, which may be a positive, especially if your patient might be more sensitive to the effects of those agents. As you can see here, they can be used in combination with levodopa, or if you had potentially a CYP1A2 inhibitor on board, which we'll talk more about a little bit later. So looking at the symptomatic care for these patients, so again, by utilizing the anticholinergics, this is going to help block that excess acetylcholine that's being released within the substantia nigra. This is going to be good for patients with more tremor as their main presenting sign, but with minimal hypokinesia. It's really going to help with those tremor effects, but it's not necessarily going to deal with patients who are mainly being affected by hypokinesia or more rigidity. You definitely want to avoid it in patients with cognitive impairment. As we see with most anticholinergics, they can cause some degree of altered mental status, especially worsening dementia and things like that in older patients. So, as long as they have minimum cognitive impairment to begin with, these might be good agents for them. As you might imagine from anticholinergic side effects, you're mainly going to be looking for more of the muscarinic effects. So here we're going to see things like dry mouth, constipation, blurred vision. The confusion and hallucinations can be kind of one of the big things, especially for older patients who are more sensitive to that. And it's always important to remember that if you're going to be taking the patient off the drug, to try to decrease the dose gradually, because you're about having kind of rebound symptoms. So your patient may have, all of a sudden have excess salivation or diarrhea as a result of this. So certainly something to titrate down on as you go. The main drugs that you'll see here in the anticholinergic category are going to be benztropine or cogentin, trihexyphenidyl or artane, and then you can even use something like first generation antihistamine like diphenhydramine or Benadryl. Again, all these agents are going to have these anticholinergic activities in order to help relieve that excess amount of acetylcholine being released in the substantia nigra. Similar to how we treat the effects of dystonias in like acute dystonias in cases of patients taking kind of high potency dopamine receptor antagonists like haloperidol or fluphenazine. The same thing is going on here, is that we're using anticholinergics to help reverse those dopamine blocking effects here. Or in the case of Parkinson's, a patient who doesn't have enough dopamine to be released on their own, you're having this blockade of the anticholinergic or the muscarinic receptors in order to help prevent that effect. Another drug that can be utilized in the treatment of Parkinson's disease, this is going to be more for the symptomatic management, is going to be amantadine or Simitrel. This one doesn't really have a good, clear mechanism of action. It's actually kind of interesting because it does have some antiviral effects, especially on the flu virus. But here, where we're using it like almost like an amphetamine in the way that it's actually increasing the release of dopamine. It also has some anticholinergic effects and even some NMDA antagonist effects. We mentioned NMDA was a glutamate receptor, and by blocking this, you maybe block some of those kind of excitatory transmissions. So maybe this does have some neuroprotective effects. Hard to say at this point. But what we can see that for more, kind of initial cases of Parkinson's, kind of early stages, it can be utilized either as monotherapy or potentially in combination with some other medications. One of the big things that I oftentimes see people don't realize is that it is renally eliminated. So you really need to decrease the dose in patients with significant renal impairment. Otherwise, you're definitely going to see a lot of increase in adverse effects, including things like dizziness, anxiety, insomnia, even some anticholinergic effects that can occur from too much buildup. Interestingly enough, I've also seen this being utilized in the ICU for patients who are kind of like in a prolonged coma kind of state. So especially like in the surgical ICU, they've actually used this to help kind of wake patients up a little bit. For whatever reason, that has a kind of positive stimulatory effect on the CNS. It was able to help kind of bring patients who are on, the ventilator or long-term sedation that are just not kind of waking up on their own, can help use to waken them up. Definitely an off-label use for that indication. Notice here, though, that tolerance may develop over time, so it may be something that is kind of useful for a short period of time, and then you move on to some other form of therapy. Again, just to go back to look at our monoamine oxidase B inhibitors, keep in mind these are going to be irreversible inhibitors of monoamine oxidase B. Because it focuses more on the B isoenzyme than the A, you don't necessarily see as much of the effects on things like blood pressure and heart rate as you would see with something like our old school antidepressants, things like phenylalanine and things like that. But again, Selegiline, Eldepril, and Zelapar being the two brand names for that one. And then also Rasagiline being here. Things with, you want to make sure that patients are taking the medications appropriately. So things like Selegiline, Eldepril need to be taken specifically with food to help increase absorption. But then here with Zelapar, you see that they actually gets absorbed better by taking it prior to breakfast without any kind of liquids on board. Helps to increase absorption. Looking at here with Rasagiline, it is the dose needs to be kind of modified depending on the type of drugs you have on board. So again, if you're utilizing it as monotherapy, you can get away with using 1 milligram daily, with or without food. It has pretty good absorption regardless. But interestingly enough, because of the monoamine oxidase B activity that it has in order to prevent, breakdown of dopamine, if you're giving it in combination with either levodopa, which we know gets converted over to dopamine, or if you're giving it with a CYP1A2 inhibitor, or even if your patient has mild hepatic impairment, which may prevent breakdown of the drug, you actually want to decrease your dose in order to help kind of limit some of the side effects you can see with these agents. So again, they can be utilized either as monotherapy in mild Parkinson's disease, and even Rasagiline has been shown to be somewhat effective in conjunction with levodopa. But keep in mind that these were our drugs that we thought we could utilize as monotherapy as a neuroprotectant type effect. So you may want to end up avoiding levodopa if you can in combination with these drugs. Again, adverse effects are going to be including basically just symptoms of too much dopamine. So you can see things like hallucinations, anxiety, irritability, mostly just CNS effects for the most part, but and potentially even some dyskinesias as well can occur from this. Some of the things you want to watch out for are going to be the contraindications. So obviously with these, you want to avoid giving them with other agents that can potentially increase levels of catecholamines. So things like your sympathomimetics, like your amphetamines, ephedra, you certainly want to avoid adding these on as well, because again, they can just lead to too many catecholamines being around. Increased heart rate, blood pressure, things like that can occur. Also, certain opioids you'd want to avoid. I know we haven't talked about too many of these, but we will later on in the semester. But just keep in mind there are certain drugs you want to avoid mixing with these agents, just due to some of their some of the CNS effects you can see with these. Obviously, you want to avoid mixing monoamine oxidase B inhibitors with any other monoamine oxidase inhibitors. Other things like St. John's wort, which may also increase levels of things like serotonin and whatnot. So typically you want to avoid these just due to kind of more exaggerated effects from it. And then they've also seen some adverse effects from using it with general anesthetics. So it's one of those ones where if the patient's undergoing surgery, you may need to titrate off of their dose, say a week or two prior, in order to help prevent some of these the adverse effects that can develop from that. So similar to what we saw with our original monoamine oxidase inhibitors used for depression, you really want to watch out for the amount of tyramine the patient's going to be intaking. Again, the reaction here is not going to be so severe as you would see with those old school monoamine oxidase inhibitors, but by intaking too much tyramine, that in turn gets converted over to catecholamines, which will be blocked from metabolism by these monoamine oxidase B inhibitors. Again, by having drugs selected for the B isoenzyme, you have a little bit more selectivity. So again, the reaction is not going to be as severe, but certainly something you'd want to avoid mixing if possible. So again, looking at things like meats, you want to avoid dried, fermented, or aged meats. Anything that's been spoiled or improperly stored. Those would all have a higher amount of tyramine. Looking at things like vegetables, you want to avoid things like fava beans. You want to avoid aged cheeses. All kind of the good stuff in life you probably want to avoid. So things like red wine, unpasteurized beer, things like that. All of those have a high amount of tyramine that you want to avoid. So that way they don't get too much of the tyramine. Moving on, you can then have dopamine agonists, which will also work for symptomatic management here. We can see the dopamine 2 agonist specifically, how these are going to work. You can have two breakdowns of this. You have ergot derivatives and non-ergot derivatives. Ergot is just a type of fungus where originally many of these drugs were originally derived. Ergot fungus is also where the drug LSD was originally derived as well. So obviously lots of CNS effects that can be occurring from utilization of some of these ergot derivatives. These may be used as first-line monotherapy, especially for more mild disease, because it's not nearly going to be as effective as carbidopa, levodopa, as we're going to talk about a little bit later. As you see, as disease progresses, less than 20% of patients are going to still be maintained on this after 5 years. One of the things we want to look at is that if you're going to be using it in combination with levodopa, you certainly want to decrease your dose down by around 20% or so. Otherwise, you run the risk of having kind of too much dopamine activity, could lead to some side effects. Adverse effects wise, CNS effects are going to be the biggest things we're going to be seeing here, including things like somnolence and confusion, hallucinations, and then potentially even something like nausea, vomiting, peripheral edema that can occur. One of the other things we see, especially with our ergot derivatives, which is kind of a unique effect, may cause some of this retroperitoneal fibrosis that can occur even in some cardiac effects like some valve regurgitation. So oftentimes we don't utilize the ergot derivatives much anymore, but they were kind of our first agents that we had within this category. Looking at the ergot derivatives, you'll see that bromocriptine, pergolide, and cabergoline fall in this category. Pergolide is not currently available anymore, but certainly bromocriptine is. That's probably the one I've seen more often than cabergoline for sure. And then you have your non-ergot derivatives. Again, these are going to be more. Certainly, these are your newer agents, and when they're going to be more well utilized here, or more commonly utilized. So you have pramipexole or Mirapex. This one undergoes renal elimination, so it's important to watch your patient's renal function as time goes on to make sure they don't accumulate too much of it. We have ropinirole or Requip. This one is metabolized by CYP1A2, so it's important to realize if you have any other inhibitors or inducers of that enzyme, you may need to adjust your dose as appropriate. And then reticotine or Nupro is interesting because it's actually a transdermal product. So especially if your patient has issues swallowing and taking their pills or remembering to do that, you can actually use this as a patch, just slap it on, and that way you don't have to worry about oral absorption and things like that. Certainly important to rotate the application site as well, because if you keep applying to the same site, you can see things like skin breakdown and whatnot. So always important when using the patches to rotate around, and also to remember to actually take off the old patch before you apply a new one. Seems like common sense, but can be an issue if you have patients who have pretty far gone CNS effects over time. Then one other dopamine agonist we have here, which is a non-ergot derivative, is apomorphine. This one I haven't seen used all that too often. It's kind of a broad spectrum dopamine agonist, so it works on all 5 subtypes of dopamine receptors. This one is given subcutaneously, and you probably will more often see it utilized as more of like kind of a diagnostic agent more than anything else. But here it's given sub-Q. You see, you actually have a pretty complicated titration regimen, so you're typically going to be seeing it utilized, start off in clinic and titrate to see what kind of doses are effective for your patient. Because it does affect dopamine, you will see some issues with blood pressure, especially if you titrate up too quickly. And a lot of these agents are going to cause positive effects on the chemoreceptor trigger zone. So it's important to pre-treat with an antiemetic to prevent vomiting from occurring. This one would be contraindicated with 5-HT3 antagonist. So those would be agents like some of your antiemetic drugs like ondansetron or Zofran. Um, uh, because of the issue with either hypotension or QT prolongation, which can occur. So you'd have to pick another type of antiemetic in order to use apomorphine along with this. So finally, one of the other categories of drugs here is going to be not necessarily to give a dopamine agonist itself, but more to utilize, try to utilize the body's own processes to help produce its own um, dopamine. So we have this combination drug here called levodopa carbidopa. It's a combination product, and the brand name is Cinemat. And so what you have here is that you have levodopa, which is the precursor to dopamine. It's able to cross the blood-brain barrier and get converted to dopamine by that LAAD enzyme in the striatum. Um, peripherally, what we end up seeing, if it gets converted over to dopamine, you can see issues with nausea, vomiting, arrhythmias, and orthostatic hypotension. So, we don't necessarily want to get it converted to dopamine in the periphery, but certainly within the CNS, we definitely do. So instead, what we can do is give a combination product that contains carbidopa. And carbidopa actually doesn't do anything positive for the effects of Parkinson's itself. What it does is it kind of acts kind of similar to if you think about like a beta-lactamase inhibitor with amoxicillin. So giving clavulanic acid doesn't actually kill the bacteria, but it lets the amoxicillin work better. And so what carbidopa is doing here is it helps to inhibit peripheral LAAD. The drug itself does not cross the blood-brain barrier, so it doesn't prevent conversion of levodopa in the CNS over to dopamine, but it definitely does peripherally. So it helps to reduce some of the adverse effects while allowing the levodopa to act centrally where it needs to go to be effective. It has pretty variable pharmacokinetics, so it's absorbed by kind of this saturable transport system within the duodenum. So what we end up seeing is that other amino acids within the diet actually can compete for absorption. So if you're eating kind of like a high protein meal, you can actually end up preventing absorption of your Cinemat in these cases. Also, amino acids in the plasma also can compete for transfer of the levodopa through the blood-brain barrier by these same kind of facilitated diffusion systems. Half-life is around 1 hour for levodopa by itself. It ends up being extended to about 1.5 hours when it's combined with carbidopa. That's due to that inhibition of that LAAD enzyme. And then when you add that with a drug like entacapone, which is a COMT inhibitor or catecholamine O-methyltransferase inhibitor, you actually see an even more extended half-life. So this is why you'll end up seeing some drugs, some enzyme inhibitors being added on to levodopa carbidopa in order to help prevent the drug from being broken down quite so quickly. So you can utilize Cinemat either as initial therapy for Parkinson's disease, or if you can utilize it after other less effective treatments have failed. Usually patients try to you try to maintain your patients off with other agents before you move on to Cinemat, because usually once they get started on this, they are generally not going to be coming off of it for the most part. So it's kind of like using insulin for diabetes. You try to use oral agents whenever you can until those aren't really effective, and then you switch over to insulin. So similar to this here. And eventually all patients with Parkinson's are going to require use of levodopa carbidopa at some point. At some point, all those other agents are going to become less effective, and you're going to have to move over to utilizing something that actually gets converted into dopamine itself. Adverse effects we're going to be seeing here include nausea, vomiting, dyskinesias, and hallucinations. So see, mostly is going to be CNS stuff, but you also have a little bit of some of the peripheral effects due to some of that peripheral conversion of levodopa. So again, orthostatic hypotension can be an issue there. So looking at the products we have available, we have just the regular normal release Cinemet. There's in here that you're going to be titrating the drug based on both efficacy, but also to help them try and minimize some of the side effects. You kind of start at a low dose and gently titrate up in order to help prevent some of those adverse effects. With Cinemet, you also have a continued release formulation, so it's going to be more long acting. So you're going to be seeing here that you're adjusting the dose every few days or so, just due to the longer half-life with this, how it's being released over a longer period of time than you do just the normal drug. And then you also have Parcopa, which is a orally disintegrating tablet, which is good for your patients who have a hard time swallowing in those cases. So, there's a lot of controversy existing between your initial choice of therapy. One of the things that we've kind of talked about already, especially with the neuroprotective effects, is that levodopa is not necessarily going to be super good on your system for long term. People worry about more increased levels of dopamine being metabolized is going to make more free radicals, which can damage other neurons. And then also the dyskinesias that seem to be more common with levodopa than you would see with just a dopamine agonist by itself. But we do know that levodopa does reduce mortality in Parkinson's disease, especially in long-term treatment. So again, the question is, can we start off with one of these other dopamine agonists or monoamine oxidase inhibitors, and maybe help to induce some neuroprotection, and then switch over to levodopa once those become ineffective? Again, the correct answer is not really out there yet. It'll probably depend on the patient and the provider and how they feel about it. Next, we have our COMT inhibitors, our catecholamine O-methyltransferase. This is going to be helping to inhibit COMT peripherally to help increase central levels of levodopa and help to prolong the half-life. So these are really only going to be used as an adjunctive agent in patients receiving levodopa carbidopa. Again, because this is going to increase levels of levodopa, you generally want to decrease your dose by around 25% or so of that when you're initiating therapy, just so you avoid having kind of more exaggerated adverse effects. And then again, if you're going to be taking it off, again, taper off of these doses of the COMT inhibitors. Otherwise, you may have kind of more drastic decrease in levodopa concentrations and lead to some exacerbations of your Parkinson's symptoms. These are going to be contraindicated in combination with monoamine oxidase A inhibitors. So that would be like your old school antidepressants, which again we don't see all that too often nowadays, so it shouldn't be much of an issue. And then you will mostly just see side effects that are going to be related to potentiation of the effects of levodopa. So kind of what we've already covered. So things like dyskinesias, orthostatic hypotension, nausea, vomiting, and diarrhea. One thing to note though is that specifically with these is that you can see kind of a brown-orange discoloration of the urine, which normally is pretty concerning for things like rhabdomyolysis, but in this situation it is a normal side effect of the drug. You see two drugs that fall in this category, so it would be tolcapone or Tasmar, and then also entacapone or Comtan. You end up seeing a black box warning for hepatotoxicity with tolcapone. So again, if you're going to be checking LFTs at baseline and then pretty frequently from then on out, and if you end up seeing a bump in your LFTs, 2 times above the upper limits of normal, then you would want to discontinue use to avoid that hepatotoxicity. And then on the entacapone, again, we have actually one of the nice things, there's a 3-way combination product called Stalevo that actually has carbidopa, levodopa, and entacapone already built into it. So when you're looking at kind of an initial treatment algorithm for how you would manage Parkinson's disease, essentially what you're going to be seeing is, once you have the diagnosis made, you want to look at their quality of life. Is the quality of life being affected? If no, go ahead and start things like your kind of non-pharmacologic therapy. Certainly, if you're starting to have tremors, you want to utilize things like amantadine or anticholinergics, remembering that amantadine has some anticholinergic properties itself, so it can help to deal with the symptoms of this tremor. Looking at that, then you want to look at some of your symptom severity. Besides the tremor. So if they're having more kind of mild effects, this is where amantadine or monoamine oxidase B inhibitor will be utilized. But if you're having more severe effects, more moderate to severe, that's when you want to look at utilizing things like dopamine agonist. And then again, if those are not working, then look at moving on to levodopa carbidopa. So the way that essentially the pharmacotherapy progression is going to be going for Parkinson's disease is that early on in treatment, you're going to be utilizing monotherapy. This is where you see your amantadine, your dopamine agonists, things like that being used by itself. Whereas eventually as we move on, we're going to end up seeing polytherapy. We're going to need multiple agents in order to help kind of manage these symptoms. And then finally, kind of late stages, you kind of move back to monotherapy. We'll talk about what that'll mainly consist of as we move forward. But essentially, what we're going to be seeing here is that we're going to have this kind of levodopa honeymoon, where over time, we'll see levodopa actually end up causing either more problems or become less effective. But essentially, levodopa is just not going to be enough on its own over time as they have that progressive loss of those dopaminergic neurons. So some of the problems that we can see more late complicated Parkinson's disease, especially as levodopa becomes less effective over time, can kind of be broken up into a couple of different categories here. We can have these motor fluctuations in which we either have a delayed onset of activity from the drug, or we can actually end up having early wearing off, where the levels of levodopa will drop quickly enough to where that we'll end up having a recurrence of our symptoms. You can also potentially even have this kind of unpredictable on-off, where it's kind of difficult to determine when the drug will necessarily be effective. In even some cases, you have very severe issues where catatonia can happen, kind of this freezing that occurs, where you end up kind of having to move on to much more significant treatment in order to help manage this. This is where we can see things like surgery being utilized, apomorphine, different things. But usually we try to avoid this state if we can. Dyskinesias can occur where having too much dopamine activity. So if you were to have too much levodopa on board, you can see a problem. And I'll show you some slides of that in a second, where you can have issues where you end up having kind of a peak dose kind of effect where the level gets far too high, or you can even eventually have kind of like a biphasic dyskinesia that can occur along with this. And then obviously, as the drug is being less effective, we'll see issues with dysphagia, dysarthria. These are much more considered to be kind of really late stage refractory symptoms. Looking at some of these motor complications. So if you look at the graph here, looking at this, we see where the dyskinesia threshold is versus where our response is. And this is kind of our therapeutic window that we'd like the drug to stay in for as much as possible, where we're having therapeutic effect, but we're not having much toxicity. Again, so this is going to be early stage in the first 5 years or so in Parkinson's, where our window here is generally going to be pretty large for the most part. So we generally have a long duration of response for the increased amount of dopamine that we're having from the levodopa, and low risk for dyskinesias. Versus when we have more moderate disease, we see our windows start to shrink a little bit. And we also start to see that our levels of levodopa are going to be depleting more quickly. Could be related to upregulation of enzymes and metabolize and things like that. So you end up seeing shorter duration of response. So where you have that kind of a little bit more unpredictable on-off or decreased duration of effect. You have increased risk for dyskinesia, mainly because your window for when that's going to occur is going to be a lot smaller than it was before in the early disease. And then in the more advanced Parkinson's disease, we'll see where we have a very short duration of response, a very high dyskinesia risk, and just pretty much a big narrow therapeutic window here where we see that kind of peak dose response that can occur from kind of those single ingestions. This is where something like maybe like a controlled release preparation might be a little bit better, because you'd not necessarily have such a high peak. You may have a little bit more controlled plateau. But here the window is so narrow that it becomes very difficult to manage the symptoms versus the adverse effects. So the treatment for the wearing off, or the basically the early offset of the drug due to it either being metabolized too quickly or loss of presynaptic neurons. Some of the things we can do to shore up its ability to work would be to do things like add entacapone, which can help the amount of levodopa making it to the CNS be a little bit higher. So again, more drug there to produce dopamine, the more effective it'll be. You could do other things like adding a dopamine agonist to where it'll kind of shore up, when you don't have enough levodopa around, it'll still be there to activate the dopamine receptors itself. Other things we could try would include administering Cinemet more frequently. So perhaps even doing up to 6 to 8 times per day will kind of give it a little bit more steady level of L-Dopa, making it to the CNS to be more effective. And then in some cases, actually, giving a Cinemet oral solution instead of tablets. This is especially useful for patients who are having issues with dysphagia, but can help to aid absorption a little bit better. And the order we're putting this in are typically the order of that you would try when patients are starting to lose the effects of levodopa, just due to the fact that we're kind of going from the least problematic in regards to side effects versus more. Moving on, you can have a monoamine oxidase B inhibitor added on. You could potentially switch over to Cinemet CR. Obviously, you need to increase your dose to account for the fact that you're giving the drug less frequently, but just the one time you take it is going to be active for a longer period of time. And then you get more severe cases where you can consider doing the apomorphine injections, which, as we said, has its own set of problems. And then even in some cases, they've used kind of constant duodenal levodopa infusions. Looking at the treatment for kind of this off dystonia, and this off dystonia is kind of described as kind of rigidity that occurs in the morning, especially when the patient has been taking any of their medications throughout the night. Definitely describes being kind of painful, especially in the feet and the toes. So some things we can do to help relieve this would be to do things like add a bedtime dose of Cinemet CR, which should potentially be working throughout the night. So that way when they wake up in the morning, they still have some degree of L-Dopa being active. Also add things like, add a dopamine agonist, add rotigotine, which remember is that transdermal patch you can apply to provide kind of more sustained action of drug throughout the night. You do things like add Cinemet upon rising in the morning, or if none of those things work, you can even do something like add botulinum toxin to the affected muscles. So similar to how we would use this for something like spasticity in certain patients, or maybe even use it for more cosmetic effects. By giving botulinum toxin, you'll actually paralyze the muscle. So if it's always your big toes that are being affected in the morning, you can inject a small amount there to prevent them from becoming having that dystonia that occurs there. For the unpredictable on-off, again, these are very similar to things that we could do when we have the early off. You can do things like try adding a dopamine agonist. Potentially, if you've already tried one, you can try a different one if the first was ineffective. You can add a monoamine B inhibitor or a COMT inhibitor. And then you can even consider doing things like doing protein redistribution. As we mentioned, amino acids can help to saturate those transporters, help to absorb levodopa and carbidopa, and also to have levodopa cross the blood-brain barrier. By redistributing protein intake in those amino acids, eventually what you can do is help to give Cinemet at a time where you were not having any amino acid intake, and help it to absorb a little bit better. And again, we've kind of seen some of these other solutions as well, including the apomorphine injections and the duodenal infusion. We were looking at things like delayed onset of action. So this is where the patient takes the medication, but it does not become effective as quickly as you would have expected. Some things we can do would include looking at reviewing their medication for drug interactions. So perhaps they're on a medication that's making the levodopa less effective. We can either time those out differently or try changing therapies. Do things like reduce protein in the diet or increase fiber. Constipation is a big side effect in Parkinson's disease, which can lead to poor absorption of the drug in some cases. You can consider discontinuing the anticholinergic. Again, the tremor symptoms may be more troublesome in those cases, but again, that seesaw balance between dopamine and acetylcholine is still intact in some cases, and so by removing the anticholinergic, you may be able to get more dopamine activity in the substantia nigra to make your drugs a little bit more effective and have a little bit quicker onset of action. Again, trying to take Cinemet before meals or sometime after meals, again, will help aid absorption. And again, all these different things are help to get the drug in the system a little bit quicker, to get the CNS levels a little bit higher. And again, looking at Cinemet CR, you definitely want to avoid this one if you're having delayed onset of action, mainly due to the fact that with continuous release preparations, you're going to be having a lower peak, but more consistent effect. So if the issue is you're not getting a peak high enough quickly enough, then you want to avoid that and instead use an immediate release preparation. Looking at some of the treatment of dyskinesias, so if you have a peak dose or especially a peak dose effect that's a little too significant, so looking here, you see above the dyskinesia threshold, if you have a drug level, especially with a immediate release preparation that gets such a high peak, can cause dyskinesias here. Some of the things we can do would be to lower our Cinemet dose. We could also discontinue other agents or potentiating levodopa. So if you have a monoamine oxidase B inhibitor or a COMT inhibitor, you could take that off. Potentially by adding a dopamine agonist, this may help to kind of even out some of the dopamine activity and prevent some of those peak actions from happening. And in some cases, even drugs like clozapine or propranolol have been shown to inhibit some of the actions of some of these peak effects. But again, that wouldn't be your normal. This would be more for resistant patients. Certainly lowering your dose or removing a COMT or monoamine oxidase B inhibitor would be a more an easier way to do that. If you're having issues where you're having these biphasic responses where you end up having acute dystonias, dyskinesias happening right after you end up hitting that response threshold, as you see here is kind of this biphasic effect that occurs. What you can end up doing is kind of shortening your dosing interval. So instead of giving something, say, every 4 hours or every 6 hours, you may give it every 3 hours. By having some of those overlapping effects, you kind of help to flatten this out a little bit, so you have much more of a kind of a continuous level that's occurring that can help prevent some of that. You could also do things like adding a dopamine agonist or using that controlled release formulation, which will end up having, again, much more of a plateau kind of effect than you would see with the immediate release preparation. So again, just kind of a bigger picture to remind you guys of what we're talking about with dealing with both of the diphasic dyskinesias and also the peak dose dyskinesias. For some of the other late complicated issues that come up, so the non-motor complications, for issues of sleep disturbances, we end up having, due to a lot of the motor symptoms, issues with restless leg syndrome, sleep apnea can occur, all kinds of issues that can pop up from this. Treatment is really going to depend on the type of sleep disturbance that's happening here. But ideally, if you can help to kind of optimize their regimen for Parkinson's, you can help to kind of decrease some of the sleep fragmentation that can occur. So if they're not having motor symptoms throughout the night, potentially they're not going to be having issues where they're waking up consistently and having that kind of excessive daytime sleepiness. For anxiety, it's usually a manifestation of an off state where your levels of dopamine are too low. So again, by managing the regimen and getting doses high enough to have enough dopamine around, that can help to manage some of that. And then looking at depression, which again can occur with a lot of chronic disease states. Usually you're going to see this more mild to moderate in severity for the most part. But again, obviously, treatment is going to be very similar to normal treatment of depression, but you'd also just make sure that they're kind of topped off on their regimen for Parkinson's disease. And also due to the dopamine issues that we're having here, you also can have some of these kind of control disorders that can occur. So especially if they're having issues with gambling or compulsive shopping. Again, all these things are related to dopamine and that kind of reward center. Some of the things that are considered here would be reducing the dose of their Parkinson's disease medications, especially dopamine agonists. Kind of help to deal with some of those reward center addiction kind of pathways from being overstimulated. Looking at cognitive dysfunction, again, they're going to be having issues with slowness of thought and word finding difficulty. Dementia is certainly a possibility over time. What you end up seeing is that dopamine agonists and levodopa may actually worsen confusion and psychosis in some cases. In so which cases we'll see treatment with cholinesterase inhibitors can be useful. We'll talk more about these when we get to the section on Alzheimer's disease. And then looking with psychosis, again, hallucinations generally can end up seeing these being more visual in nature, especially when upon awakening, kind of low light situations. You certainly want to rule out other issues like infection or dehydration, but if we can minimize their Parkinson's therapy as much as possible, that may be able to help with this. So things like minimizing the amount of anticholinergics they have on board, that would be one of the main culprits here. But then looking at other things like your amantadines and your dopamine agonists, make sure to check things like renal function to make sure that their doses that they're getting are not too high for them, things like that. And then also in more severe cases, you may consider using things like low-dose atypical antipsychotics. Clozapine probably be one of the more common ones being used in the past. Looking at pain and paresthesias, these are usually going to be more related with the off states. So again, by optimizing their therapy and increasing dopamine levels, this should be able to help manage this. Dyspnea may occur, can actually be in some cases an adverse effect of the ergots or associated with off states. So it would be managed pretty similar to pain and paresthesias. If it is related to one of the dopamine agonists that's an ergot derivative, you would obviously want to try switching over to maybe a non-ergot agent. And then with fatigue, obviously we want to look at things like ruling out sleep disorders and kind of treating as we saw above. And then you can even consider some therapy with things like modafinil or armodafinil. I won't talk too much about it here, but those are drugs that are useful for helping to regulate sleep cycles. You see it used a lot in patients who work night shifts a lot, and their sleep cycles are kind of affected by that, but this can also be useful to kind of help deal with the fatigue and help them get a little bit more restful sleep. Looking at the autonomic dysfunction, if they're having issues with orthostatic hypotension, you want to do things like looking at increasing their fluid and discontinuing antihypertensives if possible. Other things we can consider doing would be adding on a steroid called fludrocortisone. This is a high mineralocorticoid effect where it'll actually help to draw more fluid into the periphery or into the vasculature, so that way you end up kind of filling the vessels a little bit more and help to deal with some of that orthostatic hypotension. And then in some cases, you have to utilize a drug called midodrine, which is a direct vasoconstrictor. So it basically works directly on the blood vessels to help tighten them up and increase blood pressure. I see a lot of these patients, especially POTS patients, the postural orthostatic hypotension, tachycardia syndrome. They oftentimes will end up using therapy with fludrocortisone and midodrine to help manage their hypotension. Same thing can be used here. Looking at things like urinary disturbances, obviously we can utilize anticholinergics to help because that'll help to retain urine a little bit better, and potentially some alpha adrenergic agents. We'll talk more about that when we get to BPH especially. Then we have constipation. Obviously, can be managed with laxatives. Bulk forming laxatives are always beneficial, but maybe some stimulants and things like that. And then if we're dealing with issues of erectile dysfunction, we'll certainly talk more about this a little bit later in the urology section, but we can use things like our PDE5 inhibitors. So this would be things like sildenafil, tadalafil, and things like that. That would be normal management for erectile dysfunction. So again, a lot of the comorbidities are managed just like you would in other disease states, and so where appropriate, we'll talk about those later on in the semester. So again, monitoring. Again, we want to look at things like look at the drug administration times to kind of eliminate as many potential interactions as we can. Look at things like food intake around drug dosing or drug administration times and make sure we're not having interactions there. Oftentimes it's difficult, especially with more late disease, for the patients to understand some of the more complicated regimens. So again, having good provider or a good caregiver buy-in is always going to be really useful here. And then also want to be tracking the dose-dependent effects to look for both efficacy and toxicity here. Obviously, non-adherence is going to be an issue, especially if the patient is unable to get the medications themselves. So again, good education in the caregivers is going to be useful here. And obviously, be looking at assessing the quality of life, because obviously, if the patients are being miserable from the adverse effects, potentially some of the effects of Parkinson's may outweigh that. So again, it's going to be kind of a more personal decision between the provider and the patient here. And then obviously be screening for things like non-motor complications. So obviously more the mental effects that can occur over time, depression, things like that all need to be taken into account. So in summary, we know that Parkinson's is a pretty progressive, debilitating disease, where therapy really is going to be more based on symptomatic management, with some hopes of slowing the progression if we can. Most of the time, therapy is going to consist of either amantadine or monoamine oxidase B inhibitor, but certainly more severe disease is going to require dopamine agonists or Sinemet. And almost all patients are going to require Sinemet at some point during the therapy as things move on. As we know, motor complications are going to be more due to decreased levodopa effects. So again, this is going to be managed by increasing the dose. We're adding on things that will prevent its metabolism. And then dyskinesias are more going to be related to increased levodopa effects. So again, if our peaks are getting too high is where we end up seeing that. So again, refractory symptoms oftentimes are going to require more involved managements, but these should definitely be safe for the more refractory symptoms. Okay, so moving on, next we will be talking about Alzheimer's disease. So Alzheimer's disease, it's been known about it for some time, discovered back in 1906, and it's a very, very common neurodegenerative disease, affecting, around 4.5 million people in the U.S. and only going up, again, as our patient population gets older. We know that some cases are going to be related to some gene mutations, especially familial cases, but in a lot of cases, the etiology is not necessarily known. Certainly, age is going to be a big part of this. We're going to see, late onset, greater than 65 years of age, around a 5% incidence here, whereas 49% of the incidence is going to be in those greater than 85 years of age. And fairly slowly progressing for the most part, although some patients may have more kind of accelerated declines. And definitely costs quite a bit of money here per year, in regards to the care of these patients, the treatment, and productivity loss. So you're just looking at as the baby boomers are starting to get older and older, we're starting to see our aging population and the incidence of Alzheimer's disease increasing as it goes along with this. So looking at the neuropatho-physiology of Alzheimer's disease, basically what we're seeing here is loss of hippocampal and cortical neurons that are associated with things like memory and cognition. So, early on, you'll see things like short-term memory loss. As we move forward, you'll see issues with planning, calculation, problem solving, the issue of, safety awareness and judgment. And then, towards the end there, they have complete, identity loss and language issues and movements. This is where a lot of the morbidity and eventual mortality ends up coming from in the later stages. Looking at the hallmarks of Alzheimer's disease, you can see on the left side here we have some healthy looking neurons, but when you have patients with Alzheimer's, you start to see some of these issues with some of these tau proteins can start to form. You have this kind of bundles of cytoskeletal protein here that are inhibiting some of the neurons from functioning appropriately, and then you end up having these amyloid plaques that develop over time, which are just kind of these cores of degenerating neurons with immune cells kind of sequestering them off. And this is one of those things where, it's impossible to get a true diagnosis of Alzheimer's based on lab results, but one of those things where if you took a brain sample after death, you would end up seeing these plaques being visible. So current drug treatments for Alzheimer's disease, and unfortunately there's no magic bullets for this one, but we currently have available to us are mainly going to be working through the acetylcholine pathway. So looking at kind of the cholinergic neurotransmission-based drug therapy, we know there's a progressive loss of these cholinergic neurons, and this was what we think is associated with a lot of the decline in memory and cognition. So if we can increase the activity of acetylcholine, then perhaps we can help to decrease some of these memory issues and cognition problems. So looking at the normal function here, we're seeing as kind of the presynaptic cholinergic neuron and then we have the postsynaptic neuron here. Normally what's going to be happening is that acetyl-CoA gets converted into acetylcholine when it's combined with this choline molecule here. So eventually what you end up having is acetylcholine plus this CoA molecule. That gets broken, or that gets sent out into the neuron where it can act on the acetylcholine receptors. And then from there, it ends up getting broken down by these choline esterases. Then you're going to have the choline here, which can be reuptaken and then combined back again with acetyl-CoA to make more acetylcholine. So again, this is the normal process for normal function of these neurons. What we end up seeing is that with a normal brain, again, you're going to have normal transmission of acetylcholine, normal production, and then normal breakdown of acetylcholine. But we know that if we're having degeneration of these neurons here, so less acetylcholine is being released, we know there's going to be less transmission to these postsynaptic neurons. So the thought is, well, what if we did something to increase levels of acetylcholine by inhibiting the breakdown? This is where our cholinesterase inhibitors are going to come into play here. So by preventing breakdown of acetylcholine, you're going to have more there to function in the synapse and more activity occurring. So it's kind of more simulating normal cholinergic signaling. So looking at general considerations, some of the things we want to look at. So half-life of the drug is going to be important because obviously the longer it's available in the plasma, the better, the longer it's going to stick around, the more functional it's going to be. And we'll also look to see, look at specificity to the target enzyme. We'll see there's a few different varieties of acetylcholinesterase, and we'll see which ones we like to target when looking at Alzheimer's disease. Looking at the mode of inhibition, if you have too high of a reversibility, you end up seeing that it will the interaction between the acetylcholinesterase and the drug, if it dissociates itself too soon, you're going to end up having a reduced response over time, since the acetylcholinesterase will have a longer period of time where it's functional. Versus if you were to have a covalent modification, it would be permanently bound there and provide more sustained inhibition. This is kind of similar to what you end up seeing with looking at like nerve gases and things like organophosphate insecticides. There are also acetylcholinesterase inhibitors, but they work much more systemically, and they have this aging process where they'll actually covalently bind to the acetylcholinesterase and render it not functional for the life of that enzyme. We also want to look at things like hepatic transformation. Obviously, the more metabolism goes on here, the more chance for drug-drug interactions we see. And then we'll see kind of the general toxicity that can occur here. And then also another important thing is, does the drug actually cross the blood-brain barrier? You know, there are plenty of acetylcholinesterase inhibitors that are great at inhibiting the enzyme, but if they don't cross the blood-brain barrier, they're simply only going to be working peripherally and don't really have any effects on the acetylcholine within the CNS. So the ideal agents we'd want to use for Alzheimer's disease would be those that are centrally acting, so they need to be able to cross the blood-brain barrier. They're going to be used to treat more mild to moderate disease in these patients. And the idea is they're going to help to improve memory and cognition. But unfortunately, they're not really doing anything to inhibit or slow down the breakdown of those neurons. So of course, they're not really going to have any issues to prevent further neurodegeneration. They're only going to deal with the current symptoms of the disease. So looking at the different types of acetylcholinesterase we're going to be focusing on, we'll see that there's acetylcholinesterase, predominant form being in the brain. It's very specific for hydrolyzing acetylcholinesterase. A few different isoforms that are available within the body, but the two that we're most focused on are going to be this G1 and G4 isoforms, mainly because those are going to be more predominant within the brain. Those are the ones we're going to want to be focusing on mostly with our medications. There's also butyrylcholinesterase that you find pretty abundantly within the plasma and the liver. These are not completely specific for hydrolyzing acetylcholinesterase, and so we're going to see that some drugs will be more or less specific for acetylcholinesterase over butyrylcholinesterase, and that may help to prevent some of the systemic side effects we can see with these drugs. So just to kind of give you an idea of the few different products we have available to us, we'll get into more detail on each one of these in just a moment. So this is just more for your reference. The first one being Tacrin. This one is not very often used. It's a very short half-life and pretty low bioavailability, so it's having to give several times a day, and we actually end up seeing very significant hepatotoxicity and also a lot of peripheral cholinergic side effects, like things like diarrhea, nausea, and vomiting, mainly because it wasn't very specific for the brain isoforms of acetylcholinesterase. So since due to the hepatotoxicity and inability for patients to really tolerate it, it doesn't get used very often. Another one that is used pretty frequently would be donepezil or Aricept. This one is relatively specific for acetylcholinesterase rather than the more ubiquitously found butyrylcholinesterase. The nice thing about this one, it has a pretty long half-life of around 70 hours, so it only requires once daily dosing. It has pretty mild peripheral cholinergic effects, which is another plus for our patients, and no real apparent hepatotoxicity. One of the issues with it, though, is that it does have fairly rapid reversibility from the acetylcholinesterase enzyme, so it may lead to less inhibition and reduced response in a long-term use. This one is metabolized by CYP2D6 and 3A4, so if you do have drug interactions here, you definitely want to be screening for that before adding on this medication, which may lead to increased levels of donepezil if you were to have, an inhibitor on board, leading to more peripheral cholinergic effects. Then we have rivastigmine or Exelon. This one is going to inhibit both acetylcholinesterase and butyrylcholinesterase a little more evenly. It has a fairly short half-life here, but it is going to be covalently bonding to cholinesterase. So by doing that and having a half-life dissociation for around 9 hours, you can get away with actually dosing twice a day because due to the fact that it binds so much more tightly for a longer period of time, it doesn't really matter. It has a short half-life because it can't really be metabolized while it's still bound to the cholinesterase. Again, for this one, no hepatic transformations and no real drug interactions to speak of. For the other classes of drugs. And again, the slow reversibility may provide more sustained inhibition with more long-term use. So this might be more beneficial for your patients who are on it for a longer period of time. Then you have galantamine or razidine. This one happens to be very specific for acetylcholinesterase. It has a moderate half-life of around 7 hours, so it does require twice daily dosing. Again, once versus twice daily dosing, it might not sound like a big deal, but for your patients who have cognitive impairment, who can't remember if they even took their pill the one time, can be definitely a big difficulty. So this may be actually more important than you may think for some of your patients. Again, this one's nice because there's no apparent hepatotoxicity and only mild peripheral cholinergic effects. And very similar to donepezil, it does bind reversibly and pretty rapidly, so you may see reduced response over the long term. This one also undergoes hepatic transformation with CYP2D6 and 3A4, so you do want to watch for drug interactions there as well. There's also thought to be some play here with glutamate causing neurotoxicity. Some people believe that early on in stages of Alzheimer's disease, you have some changes in brain plasticity, and so you end up having this disruption of normal glutamate transmission, leading to a little bit overactive glutamate system. So by having too much glutamate being released here, it's thought to lead to kind of overexciting the neurons and leading to excitotoxicity and cell death. So therefore, it was thought that if you reduce activity at the glutamate receptor, you might be able to reduce some of this toxicity and improve cognition for these patients. So one drug we have here is going to be memantine or Namenda. This is an NMDA glutamate receptor antagonist. Is more reserved for moderate to severe Alzheimer's disease. It's been shown to help improve cognitive function and delay activities, and it's well tolerated by patients for the most part. Looking here at memantine, we'll see that we have the presynaptic neuron that's releasing glutamate. You can see here once glutamate has been released and acts on this NMDA receptor, that's going to lead to more calcium influx to cause excitatory transmission. And when you have that, eventually it can cause oxidative stress and eventual cell death. So by binding to the NMDA receptor and preventing glutamate from activating it, it's basically going to help to try to decrease that excitatory neurotransmission and help to reduce that excitotoxicity. So it's a fairly long half-life, around 60 to 80 hours, so it's only going to be given once daily. And fortunately, it has very little drug interactions due to it not being undergoing much hepatic metabolism. And pretty minimal side effects for the most part, maybe some headache and dizziness. The idea here is potentially it could be neuroprotective, but I don't think we have the studies necessarily to show that it definitely slows down progression of disease, but certainly mechanistically that would make sense. So at this point, it is going to be more reserved for a mild to moderate disease. So anyways, that ends up section 2 for neurology. Again, I apologize for being late on this one, but again, this is the first day that my voice has been anywhere near normal. Granted, that's a relative term. I don't know how normal my voice is normally, but anywho, if you have any questions, please either email me or save them for class on Monday. Thanks so much. Bye.